If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? Welcome back to the Driven Athlete Podcast. I want to talk about the medial elbow, all right? The inside component of the elbow. If you look right here like this, all right? So that's the inside of the elbow for throwers, all right? So baseball, volleyball, even lacrosse, and then for golf and also tennis. But for golf, as an example, they would call it golfer's elbow. All right. But this is kind of a different thing. Okay. So imagine like a young baseball player has elbow pain on the inside of the elbow. You know, there'd be risk of what we don't want to have happen to Tommy John. Okay. Tommy John injury, Tommy John surgery would be the next result. And that's just coined after a player named Tommy John who it's the procedure is named and the issue is named after. But the UCL is the ligament that connects from the medial epicondyle of the humerus to the ulna. All right. And it's called the ulnar collateral ligament. And it has a couple bands of that ligament, and the anterior band of the UCL is the one that gets frayed and some micro tearing, and it fails with a lot of, so it tears with a lot of repetitive stress placed on the inside of the elbow like that. All right, they call it valgus stress. Valgus would be like if you bent your elbow inwards and your hand away from your body simultaneously. So imagine somebody throwing a baseball at very high velocity. The inside of their elbow advances forward and their wrist and hand, it goes backwards. And that's like the layback or late cocking phase of the throw like when they accelerate to the throw. And that just causes a lot of stress on the medial elbow joint. And a passive structure that takes a lot of that stress is the anterior band of the UCL, all right, of the ulnar collateral ligament. And repetitively over time with not the best mechanics and undue stress continually with high velocity, that leads to that getting broken down. And some of the other structures in the area of the elbow can also get irritated and painful and broken down as well, all right? And the large muscle structure in that area is the flexor pronator mass, the FPM. And it's actually a handful of muscles, okay, that all insert there, okay? So there's 8 muscles that attach right on the medial epicondyle of the elbow that are influential and that all connect in that one origin or insertion point on the elbow. And that's a very vulnerable area for repetitive stress and tension at the insertion point. And that can cause like a tendonitis. All right. So that is golfer's elbow. Medial epicondylitis or medial epicondylopathy, a pathology or issue of the insertion point of those flexor muscles as they insert to the elbow. Okay. That would be like a tendonitis. And that comes also with repetitive valgus and stress of pulling and gripping, grasping exercises for the elbow. And that would be like tennis, golf, lacrosse, pickleball, racket, squash, paddle, all that like racket sports. So a lot of like swinging and wristy motions involved with hitting a ball to play sport. Another common population with golfer's elbow would be like weightlifters doing pull-ups or chin-ups and rows, because it's a lot of repetitive, a lot of tension and tensile strength requirements on the insertion point of that group of muscles on the medial elbow right here. All right. And that gets broken down over time. The question would be like, that gets broken down because it's overwhelmed and stressed because other structures aren't contributing enough. And those flexor muscles of the wrist are doing more than they can handle. All right, so that would be an imbalance of recruitment and strength. And that imbalance of muscle strength and recruitment is inherently, it's just learned. Like people, that's just how they learned how to move and groove. So as a physical therapist, we intervene to make sure that things are, the mobility of the wrist, the elbow and the shoulder and the scapula are moving well, but then also the muscles that connect to the scapula and the shoulder are contributing enough to offset the requirements of the elbow, and the elbow is not constantly overcompensating. All right. So that overcompensation and compensation patterns leads to chronic overwhelm, and then that gets broken down over time. And then the straw that broke the camel's back is when people have symptoms. Like, I don't know what's going on. My elbow is really tender. All right, that'd be golfer's elbow. So back to the thrower though. All right, that's a different story. So the structures that get irritated there, passively, a passive ligament, meaning like it's not an actively contracting tissue. It's just station. It's just a passive tendon. It's a passive ligament that doesn't actively contract. All right, like a muscle and a tendon is an active dynamic structure that contracts and relaxes, but ligaments don't. All right, so it's a passive structure. That's why we say that. And the anterior band of the UCL is what gets chronically overstretched and strained, and that can lead to micro tearing, inflammation, irritation, and then eventually maybe a more major tearing that would require surgical intervention to repair, and that would be Tommy John. So the question would be like, but why? Why is it that some throwers have medial elbow pain throughout the season and then other throwers don't? And in my opinion, this is just my thoughts, saying overuse is a cop out answer. All right, it's lazy. It's a lazy answer. Oh, it's overuse. All right, you're doing too much. Okay, yeah, dude. Like, okay, they're probably overwhelming the tissue. We know that. But if it was overuse from throwing too much, then why aren't all of his teammates or her teammates also experiencing the same medial elbow pain at the same time in the season? If they're all throwing the same volume or similar, it's because this one athlete's doing something different. All right, and we have to investigate and dive into what are they doing differently that's making these symptoms manifest through the elbow and expressing in the elbow. It's because the medial elbow is overwhelmed, right? It's overcompensating, or there's too much stress placed on the elbow for that throwing motion. What are they doing different then? All right, and usually what we find, the irritated structure, people want to know like what's painful is the UCL and then the flexor pronator mass. That muscle, that group of flexor muscles in the wrist that connect to the elbow are guarded and tense and are strained as well. Like there, a lot of overwhelm is laid on top of, required upon them. But usually the medial elbow for throwers is getting lit up twofold. They're lacking enough shoulder, external rotation, range of motion, and poor mechanics. All right, so not the best mobility distribution, like range of motion mobility throughout the whole arm. The shoulder would be the main component that's not moving enough into external rotation. And then the second thing would be not the best mechanics. So the force production of like, where is the force coming from to throw the ball really hard? If this particular athlete is only using their arm muscles to make that happen, what do you think is going to, and they're not using their core, okay, and their trunk and their pelvis, rotation and their hips, all right, to create the rotational torque to create power, and they're only using the muscles in their arm. What do you think is going to break down, right? Their arm's going to break down, all right? And a very vulnerable structure that is going to take a lot of the brunt with the force is a valgus moment or a valgus stress on the medial elbow. And the structures that prevent valgus stress, all right, it's going to be the anterior band of the UCL, and that's what's going to fail. So do it long enough with the poor mechanics and enough force and not the best range of motion distribution to distribute the force throughout the shoulder girdle and the arm and your trunk and your pelvis and your hips. Dude, that thing's going to get over. That thing's going to get broken down and lit up. So what's the solution then? Okay, if that's the lens, then how do we solve it? Well, number one, the elbow is the victim. It's not the problem. So we're not going to crush, just needling and soft tissue and cupping and crushing elbow, strengthening things. Like, of course, we do work on that stuff. But with this lens, the elbow is not the problem. It's actually the victim. So we need to play damage control with the elbow and do some motions, lotion, blood flow exercises to facilitate the healing process while also getting it to settle down, all right, for irritability and sensitivity. And then we definitely need to intervene at the shoulder. All right. So first thing I'm going to investigate is what does the pure rotation into external rotation of their shoulder joint look like? And usually it's not as good as it needs to be. Okay. So their elbow is overcompensating. Okay. The next one will be their scapula. They're getting enough upward rotation and retraction for the overhead throw position. And usually, no. All right. That's usually also a faulty thing that we find. Third thing I'm going to look at is the stability and strength of their subscapularis, which is a rotator cuff muscle on the front, on the ventral side of their scapula, okay, that connects on the spans across the front part of the shoulder joint. And that just prevents excessive anterior translation of the shoulder. So if somebody's lacking, this is a recipe, okay, we see this a lot. If somebody's lacking pure external rotation of the shoulder, okay, can't rotate back well enough, their shoulder joint's going to advance forward or anteriorly excessively to make up for that. All right, and that can cause anterior shoulder pain or posterior impingement. And then the medial elbow is going to get overwhelmed. And they're lacking rotation within their trunk and their pelvis and their hips, okay? And we would call that sequencing, all right? So like when somebody produces a strong throw force and they are in their windup and they're about to throw the ball, what is rotating first? The goal would be their pelvis, all right? Their hips, their pelvis needs to rotate and open up to begin the process sequence first, followed by the trunk, followed by the shoulder. And then that allows like a solid layback position, which is like all the way back to an acceleration phase to then the follow through for the throw. Okay. So if you're following me, the layback is like, have you ever seen a picture of a baseball pitcher, like a major leaguer, and they're about to throw the ball and they're at full stride and the ball is like way behind them and their arm is rotated backwards like 150, 60 degrees, right? That's like a ton of external rotation. That's layback. And that range of motion is necessary, all right? It's a necessary adaptation for throwers that the bone of the humerus rotates more into retroversion, and the soft tissue of the musculature and the joint capsule also grows in that fashion over many, many years of throwing that enables the shoulder to adapt to allow more external rotation of the shoulder joint, okay? That's necessary and good, all right? Have you ever heard of GIRD, G-I-R-D? That's glenohumeral internal rotation deficit. So they're going to have GIRD, but that's a good thing for throwers. They need GIRD, all right? They actually need more external rotation, all right? I'm not going to stretch. I'm not going to do a sleeper stretch. I'm not going to bring them into more internal rotation and say like that's the reason why your elbow's messed up or you're having shoulder pain as a thrower. They actually, most of the time, they need more ER. They need more of the external rotation. They need like 150 to 160 degrees at layback with all the movement components. Okay. And we would call that like full layback position. We need thoracic spine rotation and extension, scapular retraction and some upward rotation, and pure shoulder joint external rotation. Right, so those three things, and we would call that MER, the MER, the max external rotation. All right, and that comes from those three components that allows a pitcher in like baseball, like that poster, like a picture I'm talking about, where they're at full layback, when their arms way back and full stride, and their arms bent like all the way backwards. Those three components is what allows that to happen, and that's a good thing. We need to facilitate that. That's safer for the shoulder and the elbow. So a lack of those components leads to the elbow taking the brunt of a lot of the stress of the throw, and that can cause breakdown of the UCL. It also messes with, okay, if you ever see an anatomy picture of the elbow, all right, the cup component, like the tip of your elbow, is called your olecranon process. So the olecranon is like a cup that rotates over the humerus, okay, over the trochlea of the humerus. And with excessive valgus forces, the ulna and the olecranon shifts laterally and medially, all right? And that can cause what they would call kissing lesions of the bone of the olecranon tip because it's getting altered in more of a lateral direction that is causing a kissing lesion on the tip of the olecranon as it abuts against the trochlea of the humerus. And over time, that can also cause stress fractures in the olecranon or the distal humerus, all right? Just from breakdown, all right? From excessive, a lot of stress, high velocity with poor mechanics, And then you can say, yes, overuse, as in like it was just a lot of repetitions. It was just overwhelming volume with not the best mechanics, compounded over many episodes. And that leads to like, I don't know what happened when my elbow hurts, right? Or even worse, like the straw that broke the camel's back when elbow like hit, a pitcher has his elbow pop, all right? Like, and just like, that's just absolute failure moment of the ligament, okay, of the UCL. So those are all the components we're looking at, all right, with the medial elbow for a thrower. Like if the medial elbow hurts, the painful structures are usually the UCL band, the medial joint line, the capsule, okay? The flexor pronator mass can be guarded and tense. The olecranon tip can be irritated of the bone because it's abutting against the trochlear of the humerus with the altered valgus mechanics. And that's what's painful. But it's a victim because they're not having enough shoulder external rotation. The scapula isn't retracting and upwardly rotating well enough at layback into mid-acceleration of the throw process. Maybe let's investigate their thoracic spine. It's not rotating or extending well enough at layback as well. And then they have an issue with sequencing. Okay, so strength. Core, pelvis, trunk rotation, initiating the movement for the actual torque of creating the throwing moment. All right, glutes play a role with that, and the core plays a role with that. Enough hip mobility plays a role with that, so we're going to investigate hip mobility. Okay, and then some of the strength in the shoulder joint, like the subscapularis, is a key player as well, just to prevent altered mechanics in the shoulder with that aggressive throwing motion at full layback or late cocking to mid-acceleration where they're actually producing the force. So they need to produce more force with their core and their trunk, their pelvis, and their glutes. Enough hip mobility is important. Enough shoulder mobility is important. And then the sequencing of what rotates next to next and next, and the sequence of rotational force and torque. Or a lack thereof, they're only using their arm, and their arm is muscling the throw, is what we would say. And they're also short arming it because they're lacking rotation, range of motion in their arm. And that over time makes the medial elbow components break down enough to the point where if it fails and there's enough structural damage to the ligament, then maybe surgery would be indicated. All right. But anyway, those are the things we're investigating. And it's top of mind right now because we have I've worked with a handful, tons of people, of athletes like this with medial elbow issues and manifesting into anterior shoulder pain, which is a really common concurrent thing that happens. But it's just top of mind because we're working on that right now with a young kid that as a thrower. But anyway, there is hope. All right. And there with the message I want to convey is if it's a musculoskeletal issue, all right. And let's say an MRI found that there's no tear, like not significant tearing in the UCL, or like an ultrasound guided image is finding that the UCL is intact, but you're having pain there. Well, we need to find out all those components we mentioned before. Why is the elbow getting overwhelmed in the first place? And then what do we do to intervene? All right. The manual therapy and the corrective exercises to fix those issues that we talked about. And if that's the case, that's what we do. That's the person that you need to go see, is somebody like that has that lens and the repertoire of exercise, corrective exercise selection, and also manual therapy to set it up for success. That's the best recipe, in my opinion, is manual therapy interventions to set things up for success for mobility and activation, and then corrective exercises to solidify those changes and fix the movement pattern. That's the solution over many, many weeks and months of working into that, and then progressing back into throwing again and consulting with a pitching coach, because we're not pitching coaches or throwing coaches, but we do know biomechanics and pain and where the pain's coming from and what biomechanical compensations are causing the issue. That's what we do. And then progressing back in and fixing, consulting with the pitching coach and throwing coaches for fixing their mechanics. All right. And then cues and tips and working points to fix the throw mechanics. So that's the medial elbow. All right. That's throwers pain, medial elbow throwers pain, and the difference between golfer's elbow. So if you have any questions, or if you know a thrower or anybody battling medial elbow issues or shoulder issues, give us a call. We can at least talk on the phone and see what you have going on and how we might be able to help you. And we're always open to suggestions and ideas for the podcast too, guests and stuff. So don't hesitate to reach out with questions, comments, concerns, or conflicting opinions. And we're always here to help you. We'll catch y'all next time.